All right. Well, welcome and good afternoon. My name is Jill Rankin. I'm the Executive Director for the Wisconsin Institute for Healthy Aging, and I am pleased to welcome you to today's Age Well series event, the impact of ageism on our physical and mental health, and most importantly, what you can do about it. So we're very excited to have Dr. Regina Koepp with us this afternoon. You're going to hear a lot of great information. But before we do that, I want to go ahead and thank our sponsors. So we have Bader Philanthropies that has generously sponsored this event, and Dr. Koepp's presence here in Wisconsin teaching us all about ageism and our physical and mental health. We also want to thank the Madison Community Foundation, as well as SAIL, which is Sharing Active Independent Lives, for their collaboration and their sponsorship. We have a lot of great partners here in the state of Wisconsin who are working on this issue of ageism, reframing aging, and overall general physical health that we all have. So on our journey of aging. So a little bit about our organization, just to kind of set the stage, is at the Wisconsin Institute for Healthy Aging, our mission is to improve health and well-being. So that's a very fitting topic that we're talking about today. We disseminate evidence-based programs and practices with our partners throughout the state. We have over 100 different organizations that are implementing programs and great things that are happening in our communities to develop healthy aging and allow us to live independently and have a high quality of life here in our Wisconsin communities. We also engage in public health strategies here in Wisconsin and beyond, also nationally. So working on things like social connection and fall prevention and ageism and reframing aging and disability. So lots of things that we like to bring into our overall healthy aging strategies that we're doing here in Wisconsin. So if you haven't already, we encourage you to take a look at our website. It's wihealthyaging.org. You can sign up for our Age Well newsletter. That's an e-newsletter that comes out on a regular basis that has lots of really great health education information that we can all use as on our own health and wellness journey. So we encourage you to take a look at that, sign up for the newsletter if you haven't already. And if you are already getting the newsletter, just encourage you to take a look at that. We always have lots of new and up and coming in health education information. So happy to provide that to you. Well, now I will go ahead and I'm going to turn it over to our speaker. But before that, just want to introduce you to her. So Dr. Regina Koepp, she comes to us from Virginia today, and she is Stanford trained and board certified clinical psychologist. And she is also founder of the Center for Health and Aging. So I'm going to turn it over to you, Dr. Koepp. Thanks for being with us today.
Thanks so much for having me. Just one correction, I'm in Vermont,
Oh,
so a little colder than
nice.
Virginia,
You're right.
more
It was
similar to
Vermont.
Wisconsin in weather.
Yeah.
And
Thanks.
thank you so much for having me today and for addressing this really important topic. I'm going to share my screen and we'll get started. And so here we go. How does that look, Jill? I can see you. So
Looks great. Thank you.
excellent. Okay. Well, so as Jill mentioned, today we're talking about the impact of ageism on physical and mental health and what we can do about it. So I want to share a little bit about me and my journey. So here is a clipping from the newspaper in the 80s, the 1980s. I was a sixth grade student body president. I'm in the middle of this image carrying a box of canned foods into our local food bank. I'm walking up the ramp carrying a box of food, and I'm beaming with pride because our school has, I grew up in Southern California. Our city was huge, and we had many different elementary schools. And among the elementary schools, our elementary school collected the most canned food. And so had the honor of being on the cover of our city newspaper. And here I am in the middle of this image, beaming with pride, carrying food up the ramp into the food bank. And I'm on top of the world. I'm just basking in the glory of serving my community and being lauded for serving my community, being told I should be so proud of myself for serving my community and for helping people in need, for feeding the hungry. And I'm just in this moment beaming with pride. A couple of days later, my mom picks me up from school and says we need to go to the grocery store. And we drive to the grocery store, pull into the parking lot, and lo and behold, it's the parking lot of the food bank. And my heart falls into the pit of my stomach. I want to hide in the floorboard of the car because I do not want anybody to find out that I'm the kid who shops at the food bank, that I'm the kid who's living in poverty and is the needy. And by 11 years old, by the time I was in sixth grade, I had received so many messages about um, what we should be proud of and what we should hide, whether or not that's accurate. And those messages were if you had enough to eat, if you had enough money, if you were high socioeconomic status, you had enough to be proud. And if you didn't, if you had to shop at a food bank, if you had to get things for free, if you were on welfare, if you had a single mom like I did of 5 kids and didn't know your dad, that was something to be ashamed of, something that you would want to hide in the floorboard of a car for. And so it would take decades and decades and lots of psychotherapy of my own and lots of my own work in this domain to really recognize what does it actually mean to be a person who's both a contributor to the food bank and a recipient of the food bank. And it sort of brought to light this idea that I am my community and my community is me, that I am a person who has something to offer, and I am also a person with vulnerabilities and needs. And so are you. And yet, we're given messages that it's best to be on top and it's worse to be vulnerable and with need. And my hope today is that you will join me in carrying the message all the way through that the human experience is that we each have something to give and we each have a need, and that I am my community and my community is me. And so I love this quote by Audre Lorde, who's an author and civil rights activist, who says, "It's not our differences that divide us, it's our inability to recognize, accept, and celebrate those differences." It is not that I was poor that I felt divided or like I wanted to hide. It's the shame that I was was taught to believe about the situation of being poor, of the inability to accept and celebrate the difference of having needs versus giving. And so this leads us to an important conversation on bias, on what's the difference between explicit bias and implicit bias. Like, how is it that I got the message that I should be ashamed of living in poverty or ashamed of needing food when I was hungry? As a child, as a middle-aged person, as a grown-up, as an older person, we get these messages. And so there's explicit bias, which is overt, so people being cruel and vocal about what they believe. That's harsh. It's freely expressed. It's when people are fairly clear about their feelings, attitudes, and behaviors, and it's deliberate. This is really overt and pretty hostile when people have explicit bias. But implicit bias is something that actually is deeper and more pervasive. It's not consciously acknowledged, it operates in more subtle ways. It's spontaneous and activated quickly, and it can be in direct contradiction to our declared beliefs and values. And today I'm going to be giving lots of examples of implicit bias that arise in us as individuals and what we can do about it. And here's why it's so important that implicit bias has significant impact on our interactions with people, from healthcare to mental health care to community members. It results in when we experience implicit bias and we don't check it when it happens, we experience less person-centered communication. If you're in healthcare or mental health care or aging services, you'll be less likely to provide equitable treatment recommendations or resources to clients that you have biases about. You may have less empathy, warmth, or friendliness. You might spend less time with the person that you have bias about. And nonverbal communication that signals discomfort or a negative attitude that can be felt deeply by the person that you're interacting with. And here's why it's so important related to aging and why we're going to be talking about ageism today is that the population is, of course, aging. But by 2034, in just 9 years, there will be more people 65 and older than children under the age of 18. And this will be for the first time in US history. There will be more older adults than people under the age of 18. And by 2060, you can see that the population of Americans 65 and older will more than double between 2060 and 2014. And so here's what we'll cover today. I'm going to review ageism and its impact on physical and mental health, the importance of connection and belonging, and then what we can do about it. How do we counter ageism? And so let's start with what is ageism? Let's get a real solid definition so you know what to do. Okay, so what do you see? If you can, put in the chat, what do you see in this image? Put it in the chat box. Katie says rabbit. Anybody else? Duck, duck. Rabbit and duck. Duck. I feel like I should just throw in a goose because I'm saying duck so many times. Rabbit, duck. Okay, so for the people who can only see one thing, these are the rabbit's ears, and the rabbit's profile is facing to the right, and this is the rabbit's eye. If you cannot see the duck, flip the rabbit, and the ears become the bill. So this is the bill, and this is the eye, and the duck is facing left. And so often when we think about older people, we only see one side. We only see rabbit or we only see duck. It's hard to see both. And that's because of implicit bias. And so let me ask you, what do you see? Concerned older Native American woman or a leader or a chief? Let's find out.
In 1985, Wilma Mankiller made history when she became the first woman to lead the Cherokee Nation, one of the largest Native American tribes in the United States. But the transition wasn't made easy for her. Her daughter and grandson, Gina Olaya and Kellen Quinton, came to StoryCorps to talk about the challenges she faced when she became chief.
People thought that we would be the laughing stock of all tribes if we had a female leader. There was one time when the 5 civilized tribes had like a joint meeting and they purposefully left her out.
Right. They didn't have a chair for her.
Yeah. So she found a chair, dragged it in, and forced her way up to the tables. They get through everything, and they were adjourning the meeting, and she stood up and said, "No, I have something to say."
And she was heard. People respected her fully after they gave her the moment.
And in the second election, she won by almost 83% of the vote. She did what she needed to do to prove those naysayers wrong.
Right. But to me, she was just grandma. We would be joking, dancing, and acting a fool together and having a great time.
How did you feel when she came to your games? Because you know she had that scream that everybody in the whole place could hear.
I love that other people got to see that human element of her. She doesn't have to be the epitome of strength and grace at all times. She gets to have fun too.
Mm-hmm. But your cousin still called her Grandma Chief.
Right.
You know, it took me a long time to think about whom I was going to sit across from in this interview. And I picked you because you were the closest that I had to her.
It's a gift to be here. And I definitely attempt to model myself after her. You know, I had a friend of mine whose little girl wanted to do her end of the year essay about grandma. And to hear that people still think about her. I mean, she's going to be on the quarter soon. Who would have ever imagined a Native American woman would have been on the quarter of the United States of America? I mean,
It's mind-blowing.
it really is.
In 19
Wilma Mankiller, Grandma Chief, was the first female principal chief of the Cherokee Nation, first woman elected as chief of a major Native tribe, a Native rights activist, recipient of the Presidential Medal of Freedom. In 2022, she was honored with the U.S. Quarter. She's a mother. She was a grandmother. She was coined not only on the quarter, but as Grandma Chief, and was quoted as saying, "Every step I take forward is on the path paved by strong Indian women before me." This is Wilma Mankiller, Grandma Chief. And so when we look at Wilma Mankiller and we think concerned Native woman or leader, she's all of these things. She's multidimensional and more. So rabbit, duck, sketches, more. Native American woman, concerned woman, grandmother, leader, Native rights activist, multidimensional. And so as we consider aging and older adulthood, how can we look at multidimensionally and not sweep everybody under the same umbrella? And so ageism. Ageism are stereotypes, how we think, prejudice, how we feel, and discrimination, how we act toward others or ourself based on age. They are commonly perpetuated by the media during the previous presidential election. This was the cover of the New Yorker of older people, politicians looking frail using a walker. And this sort of brought into the room not only ageism, but ableism as well, which is bias and discrimination based on ability. Common stereotypes are when older adults who defy negative stereotypes are presented, that they're seen as bizarre or comical. There are stereotypes that equate growing older to deterioration and decline. Their older adults can often be demonized as a group. So if you've heard the term, quote, boomer in a derogatory way, this is a sort of stereotype perpetuated by media. And also made to feel irrelevant or insignificant by being underrepresented and ignored socially and sometimes in families, in communities, and so on, in workplaces, and so on. And so there are three common forms of ageism. One is hostile ageism, and this is back to that overt bias, right? Overt hostility. This is where we might see people be called names, older people be called names like senile or demented, or frail or weak, or the term silver tsunami is a form of hostile ageism. And this is a term that describes the coming of age of baby boomers. So between 2011 and 2030, 10,000 people turned 65 every day. That's the baby boomer generation turning 65 every day. And that is advancing the older adult population faster than any other age group. And so that phenomenon of population shift, of more older adults in society, some people coined the term silver tsunami to make a joke about that. However, it's hostile in that a tsunami is a natural disaster that when it strikes, it depletes us of our resources and harms us and creates a natural disaster. And so we don't use the term silver tsunami because it's hostile. And I like to think of, when I hear this term, I sort of imagine Paul Revere riding his horse through the streets of Boston going like, the aged are coming, the aged are coming. It's creating this hysteria and fear that's actually not true of what's happening. And so that's an example of hostile ageism. Then there's neglectful ageism, and neglectful ageism occurs when we overlook the contributions that older people make in society, from volunteering to continuing to work. So more and more people are working well into their older adult years, to caring for grandchildren, to helping neighbors, to volunteering in community, as I just mentioned, and so on, or making older adults feel irrelevant or unimportant, not inviting them to sit on boards, and so on. And then there's benevolent ageism. And this actually, if if you find yourself or believe yourself to be a helper in the world, you might be more vulnerable to benevolent ageism. And this is where you might assume that the person needs your help even when they don't, because they may look older. And so this is where the intention is good, but the impact is harmful. And so to give an example of this, I was living in Atlanta during 2020 and during the lockdown in 2020 COVID-19 pandemic. And I was still driving to a medical clinic where I worked every day in an outpatient mental health clinic for older adults. And under the freeway overpass, there was a big freeway sign that said, COVID-19, isolate the elderly. And the sign, isolate the elderly. The intention was good. Let's protect people who are vulnerable. We know that COVID-19 at the time was disproportionately impacting older adults with hospitalizations and death, and that the intention was good. Let's protect people who will be more vulnerable. However, the impact was harmful because isolation is deadly. And so over time, the sign actually changed to COVID-19, protect the vulnerable. And so that was a much more inclusive sign because there are many other groups who were actually also vulnerable to COVID-19, not only older adults. And so as we think about ageism, ageism can occur in a structural way or in an individual way. And so in a structural way, ageism occurs with sweeping denial of access to health care for older people. So if you're an older person in the room and have heard, oh, you're in pain, you're old, what do you expect? Or there's not much we can do for you because of your age. Or even if, so this is I'm going to give an example of an intersection between ageism and ableism, but I'll have clients who are older who also may have a dementia disorder, and the caregiver is advocating for physical therapy or occupational therapy to help them optimize their functioning. And when a health provider says, well, they have dementia, I don't think that that's going to be a helpful or useful tool right now, that might be an example of ableism and ageism intersecting. So that's also an example of having resources like medical services rationed due to age, exclusion of clinical trials. We're looking for people for our depression study between the ages of 18 and 64, but then we're not getting research on older people. Limited work opportunities and workplace discrimination, that's an example of structural ageism. And then when it comes to individual ageism, there's a concept called the stereotype embodiment theory. And this was coined by Dr. Becca Levy out of Yale. And she suggested that stereotypes are internalized across the lifespan. So remember, the stereotypes that I had internalized about classism, about a child living in poverty, coming from a fragmented family, that I had already internalized those by the time, I was in 6th grade, and I just wanted to hide, that they operate unconsciously and that they have a significant impact on our health and well-being and do the most harm when they become relevant. Meaning, it did the most harm. The stereotype I had about classism, about living in poverty, did the most harm when I was faced with it, when I wanted to hide in the floorboard of the car. But when it comes to aging and stereotypes about growing older, they do the most harm when we become the age that we have stereotypes about. So when we become the age where we have gray hair, when we become the age where we experience more physical changes or more medical vulnerability, that's when the stereotypes do the most harm. And here's the kind of harm that they do. So ageism has tremendous impact on our physical health. Back to Dr. Levy out of Yale, she's one of the premier researchers, the most prolific researchers on ageism and the impact of ageism on health and well-being. She advises the World Health Organization on their anti-ageism campaigns. And so in one of her research studies, she and her group found that those who held more negative age stereotypes, like getting old is for the birds, it's the pits, there's nothing good that comes with aging, those are negative age stereotypes. And that when people had more negative age stereotypes, they were significantly more likely to experience a cardiovascular event over the next 38 years. And so this is an image from that study. And so this is where if you had negative age stereotypes, 38 years later, you were more likely to experience a cardiovascular event compared to people with positive age stereotypes. And it wasn't only in this one study. They looked at in another study, they looked at the same thing. And they found that those, again, with more negative age stereotypes were twice as likely to have a cardiovascular event after age 60. They also found that ageism was linked to Alzheimer's disease. And so in one study looking at people who had Alzheimer's disease, they found that the rate of hippocampal volume decline, meaning there's an area in the brain called the hippocampus, and the rate of its shrinkage was 3 times the rate of decline when you held negative age stereotypes. So if you held negative age stereotypes, like you thought aging was not good and you didn't want to have anything to do with it, then the rate of your disease would occur more quickly, 3 times the rate than if you had positive beliefs about aging. And then in another study, they looked at, okay, well, what about people who have the Alzheimer's gene but don't have Alzheimer's disease? And so they looked at people who had the Alzheimer's gene, and they found that among people with the Alzheimer's gene, those with positive age beliefs were 49.8% less likely to develop Alzheimer's disease than those with negative age beliefs. And then the researchers said this essentially or effectively put their risk as to if they didn't have the gene at all. And so how we think about aging impacts how we live, and that impacts how well or how unwell we live life. And so this is conveyed in another research study of Becca Levy's, in which they found that those who have a positive view of aging live 7.5 years longer and better than those with a negative view of aging. And that's because if you don't think that life is going to be worth living, why would you do what it takes to live it well? You wouldn't. And this is why how we think about aging is so important to our health and well-being, because how we think influences our behavior, and that behavior influences how our bodies experience disease, how vulnerable our bodies are to illness, wellness, and beyond. But ageism, it doesn't stop with physical health. It extends to mental health as well. And so let me ask you to just put in the chat, older adults are more likely to be depressed than younger adults. Myth or fact? Older adults are more likely to be depressed than younger adults. Put it in the chat. Myth or fact? Myth, myth, myth. How many of you have heard that older adults are more likely to be depressed than younger adults? Have you heard that? I have, and I'm a psychologist who specializes with older adults. Myth. Older adults are not more likely to be depressed than younger adults. As we age, our risk for depression, anxiety, and other mental health conditions decreases. Younger adults are more likely to be depressed. And this is because of something that happens as we age. It's a phenomenon that happens as we as individuals mature, that as we age, we become more and more resilient. The aging brain gets a lot of negative play in social media, in airtime, in society. People are really concerned about brain health and dementia disorders. But there are positive things that happen in our brain as well as we age. It's not all downhill. And so what happens in our brain as we age that's positive is that we become better problem solvers. We have better emotion regulation. We have better, higher rates of self-compassion. And this helps us to navigate adversity and develop our resilience. And we develop our resilience with adversity. And so as we age, we have more opportunities throughout life to move through and overcome adversity. And as a result, you see, there's actually a phenomena that happens called the U curve of well-being. And this suggests that in our young adulthood and toward the end of our adulthood, at the end of our life, we have the highest rates of well-being. So what's interesting is this study came out in about 2010. And so I looked recently at what do the current studies show about the U curve of well-being. And what they're showing is that young adulthood has lower rates of well-being now, whereas older adulthood has maintained their rates of well-being. And so this is really important because there's a lot of good that happens as we age. And it's time we start looking at that. I like to say when we only focus on what is wrong, we miss what is strong. And so as we age, as I mentioned, our risk for mental health concerns decreases. However, older adults are still human and are still vulnerable, just like everybody else, to mental health concerns. About 20 to 22% of older adults have a mental health condition. This includes dementia disorders. Yet the majority of people with mental health conditions who are over 65 are not getting the mental health care that they need. And some of the reasons for this have to do with ageism. And so ageism in mental health care plays out with misinformation about what's typical with aging and not. So if we believe that depression or anxiety is normal with aging because we're misinformed, because ageism influences our beliefs about this, then we're not going to be encouraging people that we love or even ourselves if we're experiencing depression or anxiety or difficulty. We're not going to be encouraging people to reach out for help and to get the mental health care that they need. And then there are very few people who actually specialize in the mental health care for older adults because there's limited training for professionals in graduate schools and beyond for specializing in mental health care with older adults. And these are examples of structural ageism in mental health care. And also limited research, as I was discussing earlier, on effective treatments for people over 65 for certain mental health concerns like trauma, for example. And then it plays out interpersonally. And I've heard many mental health and healthcare providers, aging services providers, probably less so aging services providers because they have more training and experience with older people, but say to me, when I say, oh, it's really important that you encourage that person to get mental health care, they're really struggling. They'll say to me, oh, they're older. Will they really benefit from therapy? Will they really change? Aren't they set in their ways? Or we might misattribute their symptoms to something else. So if the person is depressed, we might misattribute it to transitions and loss. And of course, that might be a part of it. Or we might misattribute depression to cognitive disorders, and maybe it is a part of it, or only medical problems, and also it may be a part of it. But we begin to misattribute what we see because it's easier for us to understand, but not because it's right. Or we might overgeneralize and think like, oh, all older adults are alike, or this is what older adults need and this is what they don't need. Or what I see too often is fragilizing, like avoiding difficult topics for fear that the older person cannot handle it. And this plays out especially as it relates to suicide in older adults. So older white men have the highest rates of suicide more than any other group of people. And yet we don't often have the awkward and difficult conversations with them for fear that the person can't handle it, or because we might be paternalistic as well. We might think we know better for that person than they know for themselves. And those are examples of ageism. But here's the harm it does. When mental health conditions go untreated in older adults, they have more medical problems. They stay longer in the hospital for medical problems, use more medication for their medical problems, have more visits to the ER for medical problems, experience more loneliness and isolation, have increased risk for dementia disorders, have poorer quality of life, experience more family strain, and have an increased risk for suicide. But all of these things you can see if you're experiencing worsening of health problems and have more hospitalizations and more medication, you're also spending more money on medical care. So maybe financial strain as well. And then back to Becca Levy, when we internalize negative ideas and beliefs about aging, this also affects our mental health. It increases our risk for suicidal ideation, anxiety, and post-traumatic stress disorder. And so it is really important that we're thinking about physical health and mental health, and then what we can do to help people optimize both, starting with shifting the way that we think about aging and challenging our beliefs about it. And so let me ask you another question. Myth or fact? Mental health conditions are not as treatable among older adults. After all, they're set in their ways and stuck and probably not likely to change. What do you think? Myth or fact? Myth, 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 I see. The answer is myth. So mental health conditions are not as treatable among older adults as younger. Mental health conditions are as treatable among older adults as younger adults. And actually, when it comes to substance use treatment, older adults have better outcomes than younger adults. They are more likely a year after treatment to have maintained sobriety and stayed abstinent. And when it comes to depression and anxiety, older adults have the same outcomes with treatment as other age groups. And it actually, in other studies, it shows it's protective for the brain when we're treating anxiety and depression among middle age and among older adults. And so the good news is depression is treatable, anxiety is treatable, and even adults with dementia benefit from the treatment for depression. And so I want to pause here and just say there is a lot that we can do with mental health care to help optimize the mental health of older people, and that ageism often influences the systems that prevent people from getting the treatment that they need. But by you being here and learning this, you have an important role then in sharing this information with your community. And then when you see somebody who's struggling with ageist beliefs or even who's struggling with mental health concerns, you can encourage them to reach out to their doctor for support and recommendations for care. And this now brings us to the importance of belonging. And when you do that, when you reach out to the person who you see might be struggling, who might be able to benefit from medical care for physical health and mental health care for mental health, the person is more likely to be seen and valued and feel a sense of belonging. And so I want to talk for a minute about the importance of belonging. So as social beings, we need to feel a sense of security and belonging because it is good for our health. It's actually essential for our health. And to share a story of how important belonging is, I want to introduce you to Jenna Alperin and her grandmother, MJ Seide. They recorded this interview together at StoryCorps. StoryCorps is a national nonprofit that collects the stories of Americans from across the United States and then archives the stories in the Library of Congress. And so in this StoryCorps, I want you to hear for how important belonging is to MJ Seide. And so here we go.
We've been listening to the voices of Americans across the country in StoryCorps. Today, ahead of Valentine's Day, we'll hear MJ Seide tell her granddaughter what happened when she fell in love. Seide met her partner in the early 90s. Her partner had been married and raised children. Seide soon embraced her new extended family, especially her 12-year-old granddaughter, Jenna Alperin.
How has your life been different than what you thought it was going to be?
I thought that my life was probably not one that was going to be worth living. There was this hole that I had all of my life because I never thought I'd be able to walk along the beach and hold somebody's hand because I'm gay. But, when I fell in love with my mommy, I knew that she was my soulmate. Do you know what I mean by that?
Yeah.
I'd never felt that way about anyone before. And after she had gotten her divorce from Grandpa Jim, she was very upfront with your mom. She told your mom she was in love, and it was with a woman. And that was the first time that anyone was proud to say that they loved me. That made me the happiest I'd ever been in my life. And then, when I got to know your mom and Uncle Justin, I knew that I had hit paradise because I now have a family that I can wrap my arms around.
Is there anything that you've never told me but you want to tell me now?
You know, you and I talk about most things, but this is the first time that we've ever talked about the fact that I'm gay. And I guess what I want to ask you is, does it embarrass you to have a gay grandma?
No, it doesn't really matter
It
because
doesn't.
it just matters my relationship with you.
I always tell you how much I love you, but I don't know that you can really understand the depth of it because you're someone that I never thought would be in my life, and I can't imagine my life without you. You have always been a child that makes up her own mind, and I am so, so proud of you.
Well, you're one of my favorite grandmas. You do like a lot of things with me, like ride roller coasters and play poker. I don't know what life would be like without you here.
I love you, sweetheart.
Love you too.
I love them too. So MJ said, I didn't think that my life was going to be worth living. And I don't know if you can understand the depth of it because you're somebody I never thought I could have in my life. Just how essential belonging is to the fabric of our beings and how essential family, even chosen family or biological family, either one, but how essential it is to our sense of well-being and health. And even studies, if it didn't ring true from the heartstrings, perhaps science will drive it home. So, in a meta analysis of 148 studies comprising more than 300,000 people, having social relationships increased a person's odds of living longer by 50% compared to those who had weaker or fewer social ties. And the richer and more multifaceted a person's social connections, the odds of living longer increased to 91%. I didn't think my life was going to be worth living because I didn't think I could have a family. And now look at MJ Saidi and Jenna Alperin and the bond that they have. That's where this 91% comes in, the social connections, the bonds. And so when we don't have them, isolation and loneliness in older adults is as risky to health as smoking and problem drinking, and even riskier than physical inactivity and obesity. And with the social media complex and the news media complex focusing on physical health, but not on the bonds between people, we're missing the mark on really what we can do to achieve optimal aging and connection through connection. And one of the barriers of achieving optimal aging through connection is this idea that we're all alike. And so I don't even need to ask you, myth or fact, older adults are all alike. Of course we are not all alike. But when we believe they are, and when we're not able to see people holistically and deeply and uniquely, what happens is ageism intersects with other isms like classism and sexism and queerphobia and racism. And when people hold multiple stigmatized identities, they face greater risk for poorer health outcomes due to multiple types of marginalization and the stress that comes from experiencing the discrimination related to those isms. And this phenomenon actually has a name, and it's called double jeopardy, triple jeopardy, quadruple jeopardy, and so on. And the jeopardy compounds when you have multiple minoritized identities and experience compounded effects of trauma and stress related to discrimination. And it's so important for so many reasons. But as a population, not only are we aging, but the aging population is also more and more diverse than ever before. In fact, by 2050, in just 25 years, BIPOC individuals, BIPOC stands for Black, Indigenous, and People of Color, BIPOC individuals will comprise more than 42% of the population of people 65 and older. So almost half will be non-white. And so we have to be thinking deeply and looking at people deeply. And with this belief that older adults are all alike, or that we need to create one program fits all, that's actually results in people not being seen or heard or valued for who they are. And here is another way that this plays out or this manifests. Here's a graph from the Alzheimer's Association that shows the percentage of adults who have experienced racial or ethnic discrimination when seeking health care. And so you see in the middle, Black Americans, 50% of Black Americans either regularly or from time to time report experiencing racial or ethnic discrimination when seeking health care, compared to 42% of Native Americans, 34% Asian Americans, 33% Hispanic Americans versus 9% of white Americans. People aren't receiving the same access to health care or experience in their health care. And as a result of racism-based trauma and inequities in systems from early childhood to healthcare systems, this creates health disparities. And one of these health disparities is around dementia. African Americans are 2 times more likely to have a dementia disorder than white Americans. And African Americans do have a slight genetic risk greater than white Americans, but not enough to account for this difference. We also see a similar trend with Hispanic and Latinx Americans, who are 1.5 times more likely to have a dementia disorder than white adults. And 21% of Black Americans over 71 are living with Alzheimer's disease, compared to 11% of white adults. Only 53% of Black Americans believe that a cure for Alzheimer's will be distributed fairly without regard to race, color, or ethnicity. Half of Black Americans say that they've experienced discrimination while seeking care for a person living with Alzheimer's disease. And only 48% of Black Americans report being confident that they can access culturally competent care. And then we see similar trends with LGBTQ older adults who have greater health disparities, of which are risk factors for dementia like depression, obesity, substance use, lower rates of preventive screenings, cardiovascular disease, and HIV that increase our risk for dementia disorders down the road. And so for many LGBTQ older adults living with dementia, they face unique challenges in accessing support. 40% report that their support networks have become smaller over time, 34% live alone, and up to 30% experience lower rates of access to care. Alzheimer's disease is the most expensive disease in the nation to care for. 51% of LGBTQIA plus older people report being very concerned about having enough money to live on and fear discrimination. In fact, 40% say that their healthcare providers do not know their sexual orientation because of fear of discrimination. And another report found that 78% of LGBTQ older adults go back in the closet upon entering a nursing home or assisted living facility. And so this reminds me of the experience of hiding in the floorboard of my car and just my heart dropping into the pit of my stomach and the sense of insecurity and lack of safety in that moment. And I would hate for people, and it breaks my heart to know that 78% of people are having the experience in the floorboard of their car because of lack of safety in a living community for being who they are. And so we have to then ask ourselves, why do these disparities exist? Because genetics aren't answering that question. There's, of course, bias and discrimination in society and in the health system that impact health disparities. When you're experiencing bias and discrimination, then you're going to be less trusting of that health system. There's racism-based trauma and stress that weathers our organs faster than people who don't experience racism-based trauma and stress, and so increasing risk for medical problems like dementia disorders and socioeconomic factors. So if there's more fear, if there's more bias and discrimination, it's harder to get a job, it's harder to live in communities where you have access to resources and education, et cetera. And so we have to be asking, how much injustice are we willing to accept as a fact of life? And the good news here is that we don't have to accept this injustice as a fact of life, that even a 10% reduction in the prevalence of ageism could lead to 1.7 million fewer cases of physical and mental health conditions. And so what can you do to counter ageism and other biases and isms in the world? The first is to identify and challenge your biases. So I shared some of the biases that show up earlier. The second is to shift your focus And so shift how you interact with older adults. So for me, because I'm a clinical geropsychologist, I often work with older adults who are in a really medically vulnerable stage of life, who often are living with a life-altering or terminal illness, who may be at the end of their life. And it's a very specific stage and time in life that if I'm not careful, I could generalize that to all of aging. And so I have to be sure that I broaden my lens and look around me to look consciously for older adults who are thriving, not just to older adults who, because of my clinical work, are in a very specific stage in their life. You can also shift your focus from a general idea of older adults to their unique qualities and attributions. So instead of saying, oh, older adulthood is like this, or all older adults do this, speak about people and look at each person's unique qualities and attributes. And then shift your focus from a stereotypical view of older adults to a counter stereotype. So if you have a stereotype that as we age, we'll all get dementia, which is not true, then to shift your view to other older adults who are thriving with brain health. Counter that stereotype. The third is to change the narrative. And one way to do this is with Becca Levy's ABC model of bolstering positive age beliefs and challenging ageist ideas. And so I want to share this story where a few years ago, I had a doctor who made a mistake. And I got a second opinion, and the other doctor said, yes, it was indeed a mistake. And I brought that second opinion back to the first doctor who made a mistake, and he arrogantly said, no, this wasn't a mistake, and refused to talk about it with me. And so my knee-jerk reaction inside of myself, in my mind, my knee-jerk reaction was, it's time for you to retire. I had felt so dismissed by him. My knee-jerk reaction was to harm him in my mind. I didn't say this out loud, but I noticed it pop up, this idea, you need to retire. And so the first A in this ABC model is awareness, to identify where negative and positive images of aging are found. And in this case, this negative image of aging popped into my mind. It's time for you to retire. He was in his mid-70s. But in fact, when I thought about it more deeply, when I put awareness on it, I discovered, well, it wasn't his age that was the problem. It was his arrogance that was the problem. And so I had to then put the blame where blame was due. That it wasn't on his age. The blame didn't belong to his age. It belonged to his arrogance. He was probably arrogant at 35 as he was at 75. And so you have to put the blame where it's due and then challenge it. And so then I had to challenge it inside myself to take action to make sure that it didn't root more deeply inside of me, that thought, or so that I didn't say it out loud and harm him and my future self. And so what you can do is all of these things, but also to share a message of hope by talking about what's possible with aging, not only what is hard about aging, to stop reinforcing aging stereotypes, to draw upon resilience. Instead of saying, of course they're depressed, they're old, how much change can we really expect? Or instead of saying they have dementia, there's nothing I can do to help them in therapy, shift the narrative. Stop reinforcing ageist stereotypes. And the fourth thing you could do is draw on resilience. And so I love this quote that adversity is a terrible thing to waste. Resilience is our ability to persevere through adversity and come out with lessons learned on the other side. And older adults are really well equipped to do this. I love this quote by Dr. Joy Harden Bradford. We saw that African Americans, not only with dementia, but other health conditions as well, like cancer and heart disease, experience profound physical health disparities. They're also more likely to have depression than other groups, or BIPOC individuals are more likely to have depression, LGBTQ folks more likely to have depression. But here's the thing, they are also more likely to cultivate resilience. And I love this quote by Dr. Joy Harden Bradford, who's a Black psychologist in Atlanta. who says, if it's true that we can pass trauma and dysfunction from generation to generation, can it not also be the case that we pass joy, resilience, and connection through the same mechanism? And actually, this is manifest in that despite higher physical health problems and health disparities among Black adults and higher rates of depression among Black adults and older adults, they have the lowest rates of suicide. Black men and Black women, older men, older women, the lowest rates of suicide. And this is because joy, resilience, and connection are passed through. And that's how we build resilience as well. And so another thing that you can do is to create communities where people belong. Not just some people, not just people who can afford to give to the food bank, but also people who will receive from the food bank. Create communities of belonging. And so let me ask you to put in the chat, which strategies do you currently use? Do you identify and challenge your biases? Do you currently shift your focus from the stereotype to the counter stereotype, or remind yourself, oh, I'm in a caregiving role and I have to remind myself not to assume that this is everybody's experience with aging, to shift your focus or change the narrative. We're told this is one perspective about aging, that we want to slow down aging at all costs. But what about the gifts that come with aging? Change the narrative, draw on resilience, and create spaces where people belong. Which strategy, tell me in the chat, do you currently use? Number 5, so creating places where people belong. Oops. All right, and which strategy will you begin using? Will you begin to identify and challenge your biases? Will you begin to shift your focus, change the narrative, draw on resilience? Create spaces where people belong. What will you start to do? Change the narrative. I love it. Identify and challenge your biases. Yes. Oh, people, I am still, every day I need to be doing all of these things.
I hate to jump in, but we just have about 2 more minutes before we need to wrap up.
I have 1 minute left. So here are the things I want you to take away today. Take a deeper look. Remove the us versus them barrier. Draw on resilience and create spaces where people belong, because you have an important role as community members, as family members, as friends, as helpers in ensuring people receive culturally inclusive care, resources, community supports, and friendship. Because no matter if you are at the beginning of life or the end, every person at every age is worthy of healing, transformation, and love. So thank you so much for being here today. If you would like to stay connected, I have a free guide especially for clinicians on working with older adults. And I send out a weekly newsletter on mental health and aging tips. If you'd like, I can put a link to this in the chat box and you can download it. But I'm happy to stop sharing my screen and say hello to y'all and hear some questions in person.
Great. And before we get to that, I'm just going to go through a couple few things. So if you exit out of Zoom, you'll get an evaluation. If you complete that, you will be optional to receive or win an Age Well t-shirt. And then just going through a couple of our upcoming Age Well series. So on November 10th, we have Finding Your Third Place with Dr. Richard Kite. And then on December 9th, we have prescription supplements and everything in between. So we encourage you to register for those as well. So we'll get to any questions. Feel free to type those in the chat or come off mute to ask those. Dr. Kep, I think there was a question earlier that mentioned, I'll have to double check, but I thought the suicide rates among veterans increase among older veterans. However, they're uncertain whether depression rates are factored in.
You know, I worked at the Atlanta VA for more than a decade in an older adult clinic, and I don't know the current stats on older veterans or veterans in general and suicide. I will say what's interesting about the veteran population is that among veterans who are treated at the VA healthcare system, 1 in 2, so 50%, 50%, are 65 and older who are treated in the VA system. So it skews older than even the general population. I haven't seen, because I haven't looked, so that's on me, what the current trends are in suicide specifically for veterans. But it's a good question. I don't know the answer, the current answer.
I'm not seeing any other questions.
Well, I hope y'all take what you learned here and that you share it in your communities with your friends and you start to shift the narrative and shift some perspectives in yourself and within your communities.
Well, thank you so much for joining us again, Dr. Kep, and for everyone who attended. We will be sending out a recording of the webinar, so you can watch for that. Thanks, everyone. Have a great day.